As you can see from my intrepid five dog rough girl, it is a bit cooler here in Portland. We had our first frost last night. Five has her sweater on, matching my pajamas that my wife made me. Yes. So Five Dog Rough Girl is joining us for our talk this morning, where we will cover a case from previous week through a neurocentric approach lens. And we'll talk a little bit about other things that may or may not matter in our lives. Things like weather. God, it's gorgeous. Absolutely gorgeous outside. Those of you that are on Zoom and have me here can't quite see it. Those of you on Facebook over here can. You can see the incredible fall weather we're having out there. And I hope it's nice where you guys are too. Yeah, first frost of the year last night. And we are likely to lose a few plants, but as they used to say in the country where I grew up, that first frost makes the collards nice and sweet. Let's see, what else? Had a lovely time with my friend and NCA cohort, Dr. Mark Heller, yesterday. He's visiting family here in the Portland and Vancouver area. And went out and spent some time with he and his lovely wife, Beth, yesterday. It's good to see Mark. And also, my father-in-law, Dick Truax, turned 87 this past week. And we all went out en masse last night to a Thai restaurant in Vancouver and had a lovely dinner together. So as folks are coming on here, I will go ahead and we'll talk a little bit about a case conference for this past week. So this week's case through a neurocentric approach lens is 58-year-old female who presented as a new patient with a complaint of left lateral hip and knee pain of 6 weeks duration and slow, insidious onset, no clear provocation. She notices the pain 100% of the time when she's being physically active. That includes walking. And it's fine at rest, completely resolves with rest. As far as radiation component, it goes only to the anterior part of her thigh, to her knee, and reliably goes there when she is physically active. But she points to an area over the greater trochanter on the left side as being the primary area that she feels the pain in. And her symptoms are the quality of the pain is dull and achy. The severity of the symptoms that she's feeling is relatively mild. It's only about a 1 or 2 out of 10 on severity, and really doesn't get much above that. Her chosen exercise is Orange Theory classes, which she took up with her daughter, who is 28. I also spent some time with in the clinic. And her daughter got her into Orange Theory classes going back to January of this year. So she's got about 9 months of Orange Theory classes on board before she started feeling symptoms in the left lateral thigh and with radiation into the knee. Her past health history was somewhat interesting, as you'll see in the case. Her past health history was interesting for twice previous diagnosis of melanoma without metastasis. Also interesting for a diagnosis of, at age 58, osteoporosis. That was diagnosed a couple of years ago. She had subsequently had 3 DEXA scans done at 6-month intervals, and all of them had been about the same level. So those DEXA scans, given that they were at the same level, she's a bit aversive to taking medication. So she decided against taking medication and decided instead to try exercise, which is part of the reason why she was doing the Orange Theory classes with her daughter. She very much enjoyed that community, very much enjoys the workouts, very much wants to get on the other side of her left lateral hip and knee pain so that she can continue them and hopefully get some improvement in her bone mineral density over time. Let's see, other issues. She's highly educated, she's a PhD in biotechnology. She's a biotech consultant, a principal in 3 different companies that are targeting primarily getting various drugs to market. Her undergrad was in molecular biology and neurophysiology, so I figured we could geek out together and have some fun, and indeed we did. So that pretty much concludes our history as we moved on to our physical examination with the patient. And on the physical, she was relatively height, weight, proportional. She didn't exhibit any overt antalgia, but I did notice a slight limp favoring the presenting leg as she walked back into the office. In standing, her ranges of motion in the trunk were pretty much WNL for flexion, extension, and rotation, with no provocation of symptoms with any of those movements. When I asked her to squat, she had a reproduction of her knee pain on the anterior knee. Now, in my world, most of the time when I do that, and the patient has that characteristic knee pain, I usually, depending on what my suspicions are from the history, I'll go one of 2 routes or possibly both routes. One will be that it's a medial knee pain, and I will go in and do a little dermal traction method along the saphenous nerve on the just above the inside of the knee and just below the inside of the knee, and see if that makes it better. In her symptoms were a little more at the suprapatellar tendon attachment to the kneecap, and also to the just lateral to that. So I chose option number 2 to intervene right there and see if it changes anything. And option number 2, what I mean by that is I go through the functional approach rather than focusing on structures there for a moment. And I just coached her through rooting into the floor in the same way that we have our power lifters from Kabuki do it. And the way that I coach that is I'll have the patient drop down with their hands on their knees, and I say, play shortstop with me for a moment. Thanks, Stu McGill, for that cue. And then I'll have, okay, hands up and ready. And I tell them, now I want you to think about your feet. And I want you to imagine that your feet are glued to the floor right now. And you have a desire to detach your sticky feet from the floor, but you're going to do it by rotating your feet out. So you're going to root out. And then I'll demonstrate and use the hand gesture to make sure they're getting the right thing. And if they don't, then I'll give a kinesthetic cue to the thigh and rotate each thigh outwards so that they can get a sense of that. I'm avoiding in that trying to go to some of McGill's older cues for trying to get this kind of gluteal activation on the squat, where we would put our hands on the outside of the knees and have the patient push into those. What we've learned over the years in working with athletes at Kabuki, that cue gets a person to roll up onto the outside part of their foot. And when they do that, it takes the ball of the foot, the base of the MTP there, and rolls it up off of the floor, and it becomes less weight bearing. So that can wind up causing some injuries in a clinical environment and also in a gym environment when we see that an athlete is riding on the outside part of their foot right there with a lot of weight on them. That is probably going to cause an injury to the knee at some point. So in her, when I coached her to do this rooting, just letting folks into the chat here and welcoming everybody in. Welcome, Chad. Nice to see Mark here as well on his drive back to Ashland today. Howdy, howdy. And hello, Brian, up in North Dakota. And looks like Alex is in as well. Hello, Alex. And Chad, how in the heck are you talking to us? Are you on a plane on the way to Sweden right now?
I'm in the airport in Munich.
Oh, very nice. Well, thank you for joining us on this. What are you headed to Sweden for, man?
What?
What are you headed to Sweden for?
What would you say?
What are you doing on your trip to Sweden?
I have to meet with a company I'm going to start doing some ambassador work with, a bed company out there. So I'm going to the factory and meeting the CEO and doing all that crap.
Far out. Sounds like fun. Sweden ought to be lovely right about now. Get some nice crisp weather and some leaf changing, I bet. All right. Well, good to see you, my friend. Let me get back to our case here. So this particular patient, again, to recap those of you that are coming in a little bit late, I've got a 58-year-old female with a presentation of dull and achy, low severity. We're talking 1 or 2 out of 10 pain in the left lateral hip with pretty much all activity. Her past health history is significant for 2X melanoma diagnosis without metastasis, and also interesting for a diagnosis of osteoporosis. 3 DEXA scans performed over the course of 6 months between each one. There was no change, so she's unmedicated to try to change her bone mineral density. She started her attempts to make her bone mineral density improved by taking Orange Theory classes beginning about 9 months ago. The pain began insidiously, and she wants to continue her exercises so that she can improve her bone health. So we're back
Philip,
to.
can I throw in one little thing here?
Sure, go with it, Mark.
Yeah, there's a fabulous new book out. I believe the title is Strong Bones, and it's by a guy I went to school with, Dr. R. Keith McCormick, who's a chiropractor. who is a world-class athlete. He was an alternate to the Olympics, developed severe osteoporosis in his 40s, and developed this whole model of how to test for and how to help people with osteoporosis with combination of natural medicine and medications. So just something for people to know.
All right, cool, Mark. Tell me what that name of that was.
I believe it's Strong Bones. And the author is R. Keith McCormick.
I've heard that name before. And I'm looking at maybe Great Bones. Yeah. So
Great Bones, that's it.
Yeah, I'm pulling it up on Amazon, and I will drop the link to that. Looks like it's a paperback on Amazon. I'll drop a link to that in the chat room for those of you that are here. As soon as I can figure out how to get to the chat room. There we go. Like a boss. All right, so that's in the chat room. For those of you that are over on Facebook, that's Great Bones, Taking Control of Your Osteoporosis by R. Keith McCormick. Thanks for that, Mark. I will check it out. So now moving back to our physical examination, cardinal ranges of motion in the trunk were WNL, but squat, rise, reproduce the one of the chief complaints of her pain in the left anterior and lateral knee. When I had her to functionally try to root into the floor to see if this was a tendency for a painful valgus position in the knee, it actually made her symptoms worse. So I'll commonly see that fix the pain right there. And then we at least know what our functional fix is going to be over time. And then we can, just focus a bit on some palliative work over the tissues themselves that are unhappy. Most of you that are on here that have taken any of our coursework on the NeuroCentric Approach Online Academy, where we've got 30 plus hours of continuing education for a stupidly low price. Go check it out. You can become a lifetime member like many of the people I'm talking to over here on the Zoom conference. When you are persistent and fortuitously engaged with us here, because periodically, like, I don't know, maybe a Black Friday sale or something like that, I might toss that lure in the water again to try to see if we can get some more lifetime members for a low price. But no one will ever pay less than my original lifetime members. I give you all a big hug over here. So this particular patient had pain when she rooted near the floor, which made me want to go over and do my first mention thing of a little bit of DTM along the thigh and see if that made her symptoms any better. And when I did that, she had a jump sign. I mean, it was a total 3/4 or possibly 4/4 kind of hyperalgesia over the anterior thigh, over the medial aspect, over the course of the saphenous nerve. So then I worked along the course of the saphenous nerve, and we're talking just a gentle pinch with lots of tissue gathered up. And as I worked down the medial side of the leg, it was a jump response the whole way down the leg. And as many of you already have seen with the patients, where you're using palpatory findings as a screening tool to see if you have mechanically sensitive neurology in your case presentation. The patient says, yeah, but you're pinching me, so that must be it. So what do you do then? Well, you reach over to the other leg and you do the same thing. Does that hurt over here? And she's like, no, that doesn't hurt at all. And then she has that interesting moment of, wow, I didn't even notice that that was that sensitive. All right, so now I've got my spidey sense on. It's suggesting that we've got a very normal kind of saphenous nerve presentation that you all know and love. And some of you on here that have taken the free knee course on the NeuroCentric Approach Online Academy have even seen some of that. But do I just stop there? No. What is the spinal derivation of the upstream nerve mixed nerve derivation of the saphenous nerve? That's a femoral derivative, right? So I continued my exploration by just going around with the same kind of pinchy movement across the anterior thigh. And as I worked along her thigh, it was clear that she had similar tenderness all the way across the front of the thigh. And that was all the way down from where her presenting complaint of the knee pain was. And it went all the way up to the lateral part of her thigh, where her symptomology was initially noted there. So now we've got some more interesting involvement. I've got a saphenous nerve that is apparently hot. And I've got what appears to be other femoral derivatives that are often also hot. So almost as in a way of dermatomal mapping, which I will sometimes do using a paper clip. You can just take a paper clip and flip it out so you got one pointy end and use that to kind of lightly stroke over an area and then use an ink pen with the patient's permission. And you can dermatomally map a pain presentation and then show it to them on, you know, a standard dermatome map. And sometimes that moves them out of the meat idea that something going on in their presenting area is a meat-based problem rather than a nerve-based problem. In her, she's sophisticated enough with her educational background to clearly know that we're talking about a nerve there. So I'm like, you can see that this is something going on that's pissing those nerves off, right? He's like, yeah. So we've got a dermatomal map that broadly looks at the entire front of the thigh. And as I work laterally, it goes away over the IT band, it goes away. And next up in our clinical rubric and the way that we do our lower extremity exam, I've got the patient standing there. We've just gotten through with the squat rise. I go over and have her put her hands on a little shelf to support her weight, go up on her toes, and then lift one leg, and then do toe raises or toe stands, and try to get 20 reps there. So I'm testing the S1 myotome there. And she had subjective and objective deficits on the left side, on the affected side over S1. And then when we tested the L5 myotome by having her rock back onto her heels on 2, and then pick one leg up and then toe tap 5 times, she was quite challenged in that as well. And we could see that there were some deficits there in that particular myotome as well. So now I've got clinical evidence on the exam, and this is all tested relative to the unaffected side. I've got clinical evidence on the exam of objective and subjective weakness over probably 3 different myotome/dermatomes. I've got a femoral and I've got 2 sciatic involvements. So I continued the exploration per that NCA flavor of lower quarter examination that we do by having her sit down, and I did a slump test in sitting, and her slump test Interestingly, again, sciatic derivatives here. Didn't do anything for her symptomology. Remember, those of you that took the lower quarter course, if we've got knee pain, don't only think of femoral derivatives, because the sciatic nerve actually sends a couple of shoots up to the bony structures of the joint and contributes to the innervation pattern there in the knee. So if you've got knee pain, don't immediately rule out that there could be sciatic involvement. So we do the slump. No reproduction of any of the knee pain, no reproduction of hip pain. We do a seated compression test to see if there's a hot disc. No reproduction of symptoms. Given her prior history of osteoporosis, I sat behind her with a reflex hammer and tapped the spinous processes along the spine. And I fully expected to see something show up as hot there. Absolutely nothing. Nothing was hot there. When I flipped her over and we did palpation in the interspinous spaces, a little bit of tenderness, but nothing really significant. I had her go up into a prone prop position. It was well tolerated, did not reproduce any of her symptoms. I had her move into prone press up. We did 20 reps. That did not really change her symptoms either. And when I say change her symptoms, what I'm referring to there is, as you guys well know, we use an index test, right? And our index test on this was her squat rise. So each time I would try an intervention, I would then have her stand up and reproduce that squat test. And the slump didn't, the prone press up intervention did not change the pain that she was having with that. While I've got her there in that prone position now, I continued my pinchy pinch testing, the palpatory testing for mechanically sensitive neuro. And I went along other upper level spinal neurology pathways and did pinch in flank and along the structures on the lateral part of the abdomen and the posterior part of her body. And I didn't really get any jump sign or anything there. And I kind of expected that the ilioinguinal and iliohypogastric nerves were going to be a bit hot. But remember where they come off of. They're a little higher up in the lumbar spine, aren't they? They're like L1, L2, L3. So now when that's ruled out, that starts to make me think more about something probably L3-ish, L4-ish is where our symptom presentation is. It's not an active fracture because the bone itself is not tender to percussion. Or for that matter, I did 128 Hertz tuning fork test on there, the poor man's stress fracture test, and I didn't get anything there either. So, given the presentation, my next go-to when I think that something is potentially needing screening at the IVF nerve root level, are going to be openers for Michael Shacklock's work. So I laid her on her side. Did I mention motor testing? We did a repetitive sit stand motor, and she could not do a single one on the affected left side. She could do 3 on the right side, but couldn't do a single one on the left. So I did test her on a femoral nerve tension test, and that interestingly did not reproduce her presenting symptoms in the knee, but she did have a change in the symptomology with neck movement on that, whereas she did not have any change on the other side. Okay, no. So I put her in the opener position. and we did 5 reps, held for 30 seconds each of static openers for that side, had her stand back up and do her squat rise. And she had no pain, no knee pain with the squat rise. While she's standing there, I could do a little pinchy pinch stuff. And she's like, wow, that's not tender at all now. So that's like, cool. So we've got sensory changes. And the squat rise is kind of hard to tell whether that is sensory and motor or if that's just sensory. So I had her go back to our motor test and do the sit stand on a single leg, and she could get 1 full rep out that time. So we've got observed motor changes and observed sensory changes by providing an opener at the area of the lumbar spine that I think is probably impacted here. So trying to put a narrative together as to how this makes sense. I don't think we've got a patient that's had an overt compression fracture from like a slip fall onto the butt or something of that. We've probably got something that looks like an insufficiency fracture, probably from exposure over 9 months of a rounded back posture on a whole lot of erg positions in that Orange Theory class. So now I've got a putative mechanism for the onset. I've got a way to provide palliation that she can do at home, and we can just stack that benefit with frequency done during the day several times. So I said, I want you 5 times a day. She works from home now. I want you 5 times a day to do those static openers in that way. And I want you to retest frequently during the day with your own fingers to palpate that area. And anytime you feel that sensory change starting to happen, then do those openers for me. And all we're doing there is trying to stack benefit. And as we stack benefit, we give the body an opportunity to change the metabolism of that neural tract and to heal the darn thing itself without getting too sexy about what the hell ever it is we're doing. Just assume that the patient and their ability to their body's ability to be able to do things, that their body's going to be able to figure it out. Interestingly as well, I mentioned to her, since she was bemoaning early in our history, the various financial variables that are, I guess, in the way of getting drugs to market and finding someone to pay for an RCT and things like that. I mentioned to her that if I had a wish for every single one of my female patients over the age of 40 for one exercise for them to do, it would be, what do you guys think? What would your go-to be for improving spine and hip bone mineral density in postmenopausal women?
Farmer's carry.
Yep, farmer's carry. I love it. Brian Dingzor for the win. We'll send you a NeuroCentric approach shirt or some swag at some point. I'm thinking about a shopping bag with the DTM, excuse me, yeah, the DTM logos, since that one was done by one of the illustrators at Marvel, who was the first to pen Thor for Marvel. He was a patient of mine, and he did that DTM logo. That's so interesting. I was thinking of doing a shopping bag for that, because some people have given me a little bit of pushback that all of this this stuff that we're doing with NCA is just ripping off other name systems and stuff, and it's patently not. What it is a way to organize your thinking process, your examination process, into something that makes it harder for you to get lost in the incorporation or the integration of all of these other named systems. So I like the idea that a shopping bag just provides you with a way of putting all of those alphabet soups that we've all been through into something that you can carry around, and you can pick out each one of those items as you need and make whatever recipe is most appropriate for the patient in front of you. More to come. Yeah, we'll open up a swag store at some point and get rich and famous. I'm sure that'll work. Okie doke. Back to.
But can you talk about that sit-stand test for the femoral nerve muscles? I'm not familiar with that.
Sure. It's just it's as you guys have noted in the past, rather than doing manual motor testing for L5, S1, and upstream motor derivatives, by doing manual testing, rating a 5-point scale there, which I've always kind of had a difficult time getting too excited about, because there's so much subjectivity in that testing. So early on in my career, I started to look for ways that we could make that motor testing more objective, and sometimes I would do it with the patient laying supine, and I would grab the big toe as they dorsiflex, and I would lean my body weight into it with hands on both, so that that's one way of making the manual test a little more objective. But I started moving more towards things that the patient could do, because then they can see clearly and can reproduce the testing at home when we have the possibility of maybe a disc and radiculopathy complaint, and we need to keep progressive motor weakness in mind, and the patient can clearly track that themselves at home and say, yeah, I can get, I don't know, X number of toe raises on the affected leg now, and I couldn't before. But to Mark's question, what is the sit-stand test? It is as simple as it sounds. Patient sitting on the end of the bench, and I coached them I want you to organize yourself in whatever way you need to stand up using only your right or left leg, to choose a leg and stand up. And then once they're up, I'll say, okay, now sit down using only that leg, and now give me 4 more of those. So I'm looking for 5 reps, and I'm okay with them trying to get up any way they want. And that's informative to me as well. If they have to launch themselves on one side with momentum relative to the other side, then that's valuable information to my mind. And I don't have high-low tables in my clinic. Some of you guys I know do, but you might want to change the height of it to accommodate the patient's stature and to accommodate their ability at this particular level. And for me, I just stack AirX pads underneath them, as many as I need, in order to get them up to the height that I am working with. So does that make sense, Mark?
Yeah. I think you're testing both the hamstrings and the glutes. Is that what, and you're testing L3 and L4 nerve glutes? Is that what it is? That's my next question about it.
I'll give you that. Yeah. Although most patients, when we're doing this, are not going to be able to get below 90 degrees of thigh orientation to the floor. So I am not thinking that I'm getting too much of the posterior chain. I am, if I raise them up just a little bit more so that their thigh is not parallel to the floor when we start that, then theoretically we're getting mostly the femoral derivatives on that, as opposed to the lower spinal derivatives. So in this particular test, to recap, or this particular patient, to recap, her Her index was left anterior knee pain with squatting. Our interventions that showed benefit. And her other index was the palpatory findings that we had for hyperalgesia across the anterior thigh. And we tested each one of those versus several different things to target the involved neurology from both a sensory and a motor perspective. And the things that we found that were palliative for sensory and for motor were openers. And the openers were prescribed in a frequent enough range to try to see if we can get some cumulative benefit. Email contact several days later with the patient. She was saying that she was feeling a marked decrease in her pain. I'll see her again later this week, and we will follow up on that. So interestingly, since I had a patient with osteoporosis, and she's a researcher, and I had been talking about farmers walks, and I see that Brad suggested deadlift as an intervention for that bone mineral density. Yeah, I like that a lot too. Deadlift's a little bit harder to get people around or to get people accepting. I like farmers walks as an intervention. This is one that got me and my patients through this is one that got me and my patients through the pandemic and trying to get creative with homework and no people not having access to any available exercise equipment. I'd have them get a couple of 5-gallon buckets out of their garage, and in the bucket put some water and choose enough weight in the bucket to challenge their grip after they've been walking around with it in their hand for about 60 seconds. And then I'd make sure their hands were protected on those little handles on the buckets by either putting some pipe insulation around the handle and or getting some heavy work gloves and using those. And the nice thing about the farmer's walks done that way in buckets versus using a deadlift, Brad, is the starting point for getting the weight off of the floor is much higher because the bucket itself is going to be quite a bit higher than a barbell or a kettlebell when we're pulling it off of the floor. And then when we flip the handles up, for most people, that's going to be a relatively upright starting position. So I don't have to go through a lot of coaching cues on position on that beyond just saying, here, I'm going to tickle you right here in your flank now, or poke you right here. And I want you to push that area out and make your abdominal wall nice and tight and have them generate some intra-abdominal pressure there as a way to protect the spine. So I suggested to her that we could potentially trial something that is very unsexy, but could be very useful out there for bone mineral density changes in osteopenic and osteoporotic patients by doing bucket carries as farmers walks. And of course, being incredibly careful in this particular patient, because we already think that potentially she's exceeded the mechanical capacity of a one of those spinal elements, probably and has probably a bit of a compression at, in all likelihood, L4 based on the presenting symptoms. So how do we rule that in or out? Yeah, I suggested she go back to her PCP and let's get at least a 3-view imaging of the lumbar spine, because I'd like to see on that oblique what the neuroforamen looks like as well, and what the pars looks like. So we shall see what we've got when we get that information back, and I'll share that with folks as well as a recap here when we learn more from that. My go-to, what I'm thinking I'll probably do this week, if things have continued to progress well with the overall metabolic health of that nerve as she's done more openers, is we're going to test more on the loading for the spine and see if we can get some improvements there. Of course, I'm going to go as well towards my favorite functional approach, which is the DNS functional approach. I did not mention it, but I did note in her history that she had a prior history of inguinal inguinal hernia on the left side as well. So I'm going to go in and do some work on that area from a functional perspective over time. So over long-term function, it's going to be making sure she can stack the thoracopelvic canister, generate intra-abdominal pressure while under load. Then I'm going to load steadily to try to make the bones stronger, trying to find a sweet spot between anabolism and catabolism on that loading locally, making sure that she's got adequate nutrition to be able to manage that with she's already taking vitamin D, she's already taking calcium, probably some collagen as well, maybe some liposomal vitamin C or just vitamin C to make sure that we've got those cofactors on board, and all of that is helping as well. So that is what I got for that one this week. Let's see, questions in the chat room here. Brian asks, did you do a straight leg raise on each side? Did one side feel heavier than the other side? I typically feel this on patients that do not have a very visible positive SLR. That's interesting. Are you saying heavier, which you put in quotes here, Brian, from a subjective or an objective? Are you referring to an active or a passive SLR?
Well, more of a passive with me pushing up, and I always feel like one side's just meets a point of tension, or it just feels heavier sooner, but it may not be like a, we're taught in school positive straight leg raises, symptoms and all that stuff. But over the years, I've just felt like one side's just always heavier on the affected side of the nerve root tissue.
That's an interesting finding. If I put it through that lens, I think I could probably concur that, well, the SLR, if you just look at the history of that examination and how and why it's been done over the years, it's kind of an interesting test. And, for many, many years, maybe even decades, there was kind of a strong cutoff at 60 degrees, and anything less than 60 degrees was considered to be a positive SLR, and anything more than 60 degrees was a rule out. And now we're of course seeing that there's a lot more nuance with that, again thanks to Michael Shacklock and others, from doing things like our discriminators on that test for internal rotation of the femur, adduction of the leg, and dorsiflexion at the ankle to test for meat versus nerve as the limiting reagent in that particular movement pattern. What I was getting stuck with on your descriptor of heavier was I was thinking about what the total mass of the leg feels heavier, and no, I know that's not where you're going. But in terms of that, I did do a girth measurement of her quads, and I just went 4 fingers width above the in a seated position above the patella on each side. And my memory is that she was 42 centimeters on the affected side and 44 on the unaffected side. So we had some evidence potentially of some reduced girth in the affected leg. I asked her as a follow-up what her sporting history was in her past and her handedness. Now, why might I ask her that? Those of you who are sports med geeks, what would that matter? So if she's a right-handed She mentioned that soccer and basketball were her go-tos. So what's the dominant leg in a right-hander? And she was a right-hander. That's going to be the left leg. And that's the plant leg on the kick. And that's the plant leg on a layup. And those of you that play basketball, your left-handed layup, if you're right-handed, suck too, just like mine did. So you always try to go on the left side using your right hand, and you always get that crap smacked back in your face. God, it used to piss me off. So yeah, that was one more finding on that. So then I'm looking at, do we have some sort of potential pathological process that we need to be concerned about that has this 58-year-old with osteoporosis and a prior history of melanoma? And do we have some sort of pathological process that's causing a putative insufficiency fracture? Yeah. And how do we kind of at the highest level of scrutiny check that out? We get an x-ray of that area. So we've kind of got that base covered as well. If we don't see things trending in the right direction there, I might consider some blood work as well to see what's going on and get our PCP in the loop on this. But I'm feeling pretty good about the way this was going, and I'll follow up on it later with you guys. Let's see, over here on Facebook Live, Ian Boonstra. It's been a while since I've seen your name, sir. I hope you are well up in BC. And welcome to Preston Hart as well. Thank you guys for joining us today. Do you guys have any questions regarding our case today, or do you have any successes or some challenging cases that you're seeing that you are interested in? Alex, well, I've got you on here as well. I have been handing out your, I can't remember the name of them, and I apologize for that. So you can weigh in here if you like on the chat. But Alex is helping someone design bra strap pads for women that disperse the force of the bra strap on our busty female patients. And I've got a few patients in that regard that have suprascapular nerve involvement, where their bra strap is going in right over that suprascapular notch on the scapular spine. And that does seem to be helping Alex on.
Thank you. Appreciate it.
Yeah, absolutely. So what's the name of that appliance, Alex? And where can folks?
Yeah, it's called a shoulder shell, and you can search the shoulder shell. It's made by an occupational therapist, and he's actually getting ready to move to Germany. So he would love to help make sure some of his supply gets out before he goes to assignment at Landstuhl. He's going to be helping the military out there. But he's works for the military also with me in the pain clinic at Madigan up here at Fort Lewis. And he's designed this because he's noticed a pretty persistent problem, especially for our military members that are carrying heavy rucks, that are having difficulty with their shoulders and that are already predisposed by the issue because of the posture of the large breasts. And this has helped them quite a bit with their symptoms. So thanks for mentioning it, Phil.
Oh, no worries, Alex. Thanks for helping get something out that addresses an issue that many of us experience with some of our patients. But short of what you're describing here, what's the thing that most people, most women posed with that particular dilemma start to consider is breast reduction? And I've had several of those patients over the years, and something like this could have been a nice thing to offer as intervention that's relatively simple, cheap. Let's see, the one thing one patient had as feedback on that was that her sports bra, which I've seen lots of women that are busty like that, they gravitate towards a sports bra that has a wider profile, and the sports bra they had more difficulty getting to fit on that, and found that when
Sure.
they used it with a sports bra, it tended to keep popping out when they were physically active. So
I
that's
appreciate that.
for your mate to think about as possibly a sporty variety that has a
Yeah,
wide catch that slips over the strap there.
great idea. I'll pass that feedback on to Mr. Sanford, see what
Cool.
he can come up with. Thank you.
No worries. How's your dad, by the way?
He's doing good. He's still running. He actually did the Portland Marathon. We finished up. I did the last 10K with him. He's just, he's one of those wonderful freaks of nature and keeps on teaching us how to live well and live right. So
He
keep
does.
on following him.
He does all of that. How old is Art now?
He is going to be 85 in December.
Far out. So
Yeah.
for those of you that don't know, Alex's father is Dr. Art Walker. Art was a mentor of mine here in Portland. He was one of the first people to turn me on to Graston technique. I think I became the third person in Portland to use that after Ted Forkham and Art. And Art actually showed me a seated T12 manipulation that I use every single day in practice. And and every single person is it's like, oh wow, that felt great.
That's
So
fantastic. Thanks, Phil.
you can pass that on to Art at some point too. And when you next see him, give him a big hug for me.
Will do.
Delightful person. All right. So what other questions, comments? You guys have any interventions, any patients that you have worked with from an NCA perspective? We've gotten really good feedback on the shoulder course. The feedback on those, if you guys note, when you take the courses at the end, that feedback is really helpful to us, both positive and negatives. The idea is going to be to grow this thing over time into something that is more effective and has better outcomes. And I don't have all the answers, of course, but collectively we can kind of crowd source some of this information and make it better. One thing that is coming up as well that I think those of you that are members should concern yourselves with is, as this grows, the term NeuroCentric is going to be more popular, and you and we should capitalize on that. Again, NeuroCentric approach is a registered trademark. So that combo platter of those two words together is ours. But the word NeuroCentric is going to get busy out there. For those of you that are bothered by social media and marketing on social media and marketing your clinical presence, part of what you're doing with this process with NeuroCentric approach is trying to, one, just be geekier and learn more so that you can help people better. But I freely suspect that many of you are also trying to do this to help position yourself in your community as being someone that's got a little bit of an edge, something that's different from the other people in your community. And indeed, what you'll find over time, in the same way that I have, is that information, whether you want it to or not, will get out. Patients will start talking to their doctors will start referring in. I stood in front of the whole physiatry department at Kaiser Permanente, 25 or so specialists, and told them about dermal traction method once upon a time, based on a similar kind of patient that was scheduled for surgical intervention for a hip, and one treatment using DTM, and their hip pain dropped from a 9 out of 10 to a 1 out of 10, and then they took the rest of it away in the next day or two. So as you start to do this, the word will get out. So in your in your blog posts, things that you do on your own sites, make sure you start to mention the word NeuroCentric, so that as patients start to look for that, you are the one that shows up in your community as having some attachment to that. And feel free to provide a link to our site, which those of you that are savvy in all of this know what that means, is that we start to get backlinks as well. So it all starts to support everybody involved here. Okie doke. So we are 1 hour in. I see the children encroaching in some of our lives back there in the background for Brian. So we've all got our respective lives to get on with. And unfortunately, Spencer drops in here, Spencer Bell, on the tail end of this. Good to see you, my friend. I hope things are good up there in Canada. I think you're still in the Toronto area, if I'm correct. But I wish you all the very best. We'll do this every weekend at 9 a.m. Pacific. Grab a cup of coffee, bring your questions, bring your comments, and let's make this thing a little better and be able to help people out there a bit better. I wish you the best. Take care. Take care.